Hello and welcome to the inaugural episode of About the Face, the new podcast series of the Facial Plastic Surgery and Aesthetic Medicine Journal, sponsored by the AAF-PRS. In this series, our aim is to connect you with the latest research and important topics in facial plastic surgery. Today's episode will be a journal club review where I will highlight an article recently published in the journal to give you a snapshot overview of that article. We hope this provides you with a concise synopsis of the research to help keep you up to date while you're busy and on the go. Throughout the About the Face podcast series, we'll also bring you author interviews and discussions on leading topics or controversies by thought leaders within the specialty. So stay tuned for future episodes. Today's Journal Club review will discuss the article Septal Perforation Repair using a Temporal-Parietal Fascia and Polydioxanone Plate Construct, a multi-institutional analysis. This was written by Seth Davis and colleagues. Complete details can be found by accessing the full-text version of this study through the Facial Plastic Surgery and Aesthetic Medicine Journal homepage. This study is a nice example of collaboration across institutions, and it features patients recruited from 7 medical centers, including Vanderbilt, LSU, Iowa, North Carolina, Massachusetts Eye and Ear, Colorado, and Utah. The authors aim to answer the question, do patients from different regions in the U.S. report good outcomes with septal perforation repair using the PDS plate and fascia graft reconstruction? The results demonstrate 95% of patients, regardless of location, achieve closure of their perforation and symptomatic improvement. Let's dive a little deeper and see how they got there. Septal perforation is a challenging entity to treat, as it can present with various etiologies, not to mention an array of symptoms and severities. Achieving successful closure is technically challenging, and multiple techniques have been described in the literature over the decades to address this problem. Most of the traditional techniques rely on some combination of nasal mucosal flap closure of the perforation, either unilateral or bilateral, along with the potential addition of an interposition graft. Fixing the perforation, however, does not guarantee that the patient's symptoms will improve, as the authors point out in their introduction. Some patients show symptomatic improvement without surgery at all, while others, despite a successfully closed perforation, continue to be plagued by symptoms. One of the issues with mucosal flap closure can be prolonged mucosal edema or alterations of the intranasal anatomy that's caused by the large amount of mucosal flap elevation that's often required. More recently, a technique has been introduced to address a septal perforation, much like we would a perforation of the eardrum, that is, using an underlay graft and allowing epithelialization rather than direct mucosal closure. This technique is carried out through an endonasal or an open rhinoplasty approach depending on the circumstances of the case. Septal flap elevation is performed around the perforation, typically only on one side of the septum, and only as far as needed to fit the graft under the mucosal flap completely covering the perforation, often extending flush with the nasal floor inferiorly. The graft uses a thin PDS plate for structure. This is made of the same material that PDS suture is made from and comes available off the shelf. The PDS plate is cut to size and then wrapped in fascia. Typically this is temporalis fascia or temporal-parietal fascia, called TPF, and this serves as the biologic construct. Once this fascia and PDS plate graft is secured in place, the repair is covered with silastic sheets or splints to avoid desiccation, and the mucosal perforation is then allowed to heal by epithelialization across this scaffold. Initial studies by several authors have demonstrated excellent results of perforation closure using this technique. I personally find this technique quite effective, and it's become my preferred approach for perforations that are medium to large in size. To improve the generalizability of these early results, this current study sought to compare results from 7 institutions across various parts of the U.S. to determine if these results were reproducible. The primary outcome measures of the study were lasting mucosal closure, with a minimum follow-up time of 10 weeks, along with improvement in nasal obstructive symptoms using the validated nose scale. The institutions were divided into geographic locations, including the South, Midwest, East Coast, and Mountain West, and patients were included retrospectively between the years of 2015 and 2021. Overall, 62 patients were included, with a little larger representation from the South and Midwest, and the lowest proportion came from the Mountain West. 63% of patients were female, and the average age was 41 years, with a range of 18 to 70. Importantly, 69% of the patients had some underlying clinical feature that could impact healing, such as smoking, hypertension, and rheumatologic disorders. Most perforations were anterior in the septum and iatrogenic in nature. Patients presented predominantly due to nasal obstruction and crusting in about 80% of cases. The average perforation size was 1.7 square centimeters, with perforations defined as small if they were under a centimeter, which was 23% of this group, medium if they were between 1 and 2 centimeters, which was the majority of 55% of the group, or large if they were between 2 to 3 centimeters, which represented about 13% of this study. 10% of patients had subtotal perforations that were larger than 3 centimeters in size. All the patients in this series underwent repair via an open approach, and 84% of patients had additional procedures beyond just the perforation repair. This most commonly included nasal framework surgery, but also included septoplasty of the residual septum, turbinate reduction, or sinus surgery. Silastic sheets or Doyle stents were then placed postoperatively for an average of just over 30 days. Now let's take a look at their results. Median follow-up time in this study was 196 days, which is just over 6.5 months. The follow-up ranged from 10 weeks at a minimum to 3 years overall. Impressively, 97% of all the patients had complete perforation closure at the initial follow-up point. 2 patients went on to develop recurrent perforation for an overall success rate of 95%. Complications were seen in 27% of patients, and these included minor complications like scalp seromas, delayed mucosalization, or nasal cellulitis, and there was 1 case each of graft extrusion, septal hematoma, and septal abscess. But remember, perforation closure rates aren't everything. What about the symptoms? Nose scores were compared before and after surgery in 29 of the patients, and they improved significantly from an average of 59 before surgery to 17 postoperatively. This represents both a statistically and clinically significant result. 95% of patients perceived subjective improvement in their symptoms that initially drove them to seek perforation repair in the first case. The most common residual symptom, though, was persistent nasal crusting. Crusting was present in 77% of patients pre-op and improved to 29% post-op, while the obstructive symptoms improved from 80% pre-op down to 13% post-op. Overall, 3% of patients had some persistent epistaxis after surgery. Finally, the authors compared outcomes and complication rates by geographic regions, and they found no significant differences in rates of closure success, symptom improvement, or complications based on the region. The one exception to this was a lower rate of persistent crusting among patients in the southern part of the U.S., which was defined by the 36th parallel. So just for reference, this puts Vanderbilt, LSU, and North Carolina in the southern group, and Iowa, Colorado, Utah, and Massachusetts in the northern group. This may suggest a role for atmospheric humidity of the locale, but this wasn't specifically studied. So what can we take away from this study? First, a key point that the authors highlight is that our goal as surgeons shouldn't be to try to fix a hole at all costs, but to have a thorough discussion with patients about what symptoms they're trying to address and what their chances are for improvement with a perforation repair surgery. Since residual crusting is the most common complaint in nearly 1/3 of patients after surgery, patients should be counseled of this risk and should really demonstrate a willingness to consistently comply with a nasal irrigation and moisturization regimen to optimize these outcomes. Secondly, this study nicely points out a fact that is often missing in many single institution studies, that is, reproducibility. We've probably all tried to employ a new technique that we've recently learned from a study or a conference, only to learn that our own outcomes aren't quite as reliable as the reports suggested in the primary study. The beauty of this technique is that as facial plastic surgeons, we already have the requisite skills for meticulous septal dissection and careful graft placement that are required. So adding this technique to your repertoire for septal perforation cases is not as big of a leap as some new techniques that you might encounter. The fact that 95% of perforations were successfully closed across 7 institutions adds to the generalizability of these results. The lowest individual geographic region had a success rate of 83%, and this represented just 1 persistent perforation out of 6 patients. There are some limitations of this study, however. Despite the nice geographic spread, there are still several parts of the country, and certainly the globe, that are not represented in this study. The overall number of patients included at 62 is also relatively modest. This amounts to fewer than 10 patients per institution. There's no control group used for comparison in this study, so we can't know how this technique compares to the traditional perforation repair techniques that use mucosal closure and interposition grafts, or how symptomatic improvement might compare with non-operative management using nasal hygiene alone. As the authors point out, we don't currently have a validated outcome measure for patients with septal perforation by which to judge our results. In this case, outcome measures included nasal obstruction scores, along with overall subjective symptom reporting, but we don't really know, among the 29% of patients with residual crusting, how bad that crusting was, or how disruptive that crusting is to their daily life. Also, the fact that many patients had concurrent nasal procedures demonstrates that while this perforation repair technique can be combined with other procedures, we can't say with confidence how much of the symptom improvement was related to the perforation repair versus these other procedures. Like most studies, the more patients we can include and the more precisely we measure our results, the more detail we can obtain to move our field forward. Overall, my takeaway from this well-written paper is that the technique of septal perforation repair using an underlay graft of PDS plate wrapped with TPF without direct mucosal closure can produce consistently high rates of perforation closure and symptom improvement among patients from a variety of geographic areas and institutions. As I've mentioned, I've personally found this technique quite successful, so you may also consider adopting it for some of your patients. Thank you for listening to this episode of About the Face, the official podcast of the Facial Plastic Surgery and Aesthetic Medicine Journal, sponsored by the AAF-PRS. I hope you've enjoyed this Journal Club review and would encourage you to visit the journal's homepage to access the full text of this and many other articles available online. Stay tuned for future episodes featuring additional article reviews, author interviews, and expert debates in topics at the center of our field.